So what I'm going to talk about is something I actually talked about for the first time over 15 years ago in terms of how population health care represents. It really falls short of the bigger opportunities of personalized medicine and community health. So just a quick audience survey first. So show of hands, how many of you have ever volunteered in a homeless clinic or shelter or anything like that? Awesome, wow, half of you. So most of you know that homelessness means you don't have a friend who can loan you first and last month's rent, and many people in that situation find themselves there because of medical bankruptcy. How many have read the blue zones? Anybody? Just 2, 3 folks in the back. I'm going to come back to that, but basically looking at 5 communities in the world where health span and lifespan were exceptionally high, and what are the underlying factors of healthy eating, sleeping, exercise, and love and social support. And how many have heard of exercise as a vital sign? Anybody? A couple, okay. So we started this about 4 years ago, and every single ambulatory visit now we inquire as to how much exercise people are doing. And there's no time for that in the physician time-pressured environment today, but we need to do the same for the social milieu as we're now doing for exercise. Anybody read Weapons of Mass Destruction by Cathy O'Neill? A couple folks, okay. A highly recommended read. What it basically reveals, there's been a lot of press about this from other sources recently, is that there is human bias in machine learning, so-called AI. And there's a systematic bias towards social inequity, so something we need to pay a lot of attention to. How many of you accessed your own digital health record online? Okay, about half. And how many have sequenced your genome? Microbiome? Couple. How many have donated your data science? Okay. And how many can name the 2 common forms of chimerism in humans? Okay, so there's actually 2 very prevalent forms of chimerism. Every mother has stem cells from each of their children. Some 2nd, 3rd, and 4th siblings have stem cells, not just of their mother, but of their older siblings. That's one form. And the other form is that there's aneuploidy in the somatic cell line that occurs in all of us, and you can actually pretty accurately date someone's age by looking at things like aneuploidy and methylation in the DNA. How many know which protections Gena doesn't cover, the Genomic Information Non-Discrimination Act? Anybody? Okay, there's 3. So it covers health insurance. It does not cover life insurance, long-term care, or disability. And here we are saying, bring us your poor, your tired, and all of your DNA, and don't worry, trust us, you're in good hands. And legal discrimination against you for life insurance is happening today. And there's an article in Fast Company about a year ago documenting exactly that. So these are the blue zones that were studied by Dan Buettner decades ago, 5 of them around the world with long health spans and long lifespans. And those commonalities that I mentioned, healthy diets with fresh, local fruits, nuts, and vegetables, and regular sleep habits, not just 8 hours a night, but the same 8 hours a night on average, but declining with age. And the thing that and regular exercise. And the thing that's most lacking from an appreciation of this brilliant work that he did is how important your social structure is in contributing to your health. So many of you have seen a slide like this, but in terms of those things that contribute to premature death, healthcare is about 10% of the total picture, even though we spend 20% of GDP on it in this country. Genetics, another 30%, social environmental factors, 20%, and our individual behavior and our daily micro choices, 40%. So what is the root cause of the problem? And I like to think that health is a very tightly linked subset of happiness, because a lot of what we do with our behavior relates to our sense of purpose and our sense of well-being, and a better integration of mind, body, and spirit is really critical. So I think there's really 4 principles to happiness that are fairly universal. Having a skill that is useful, believing that you can help your community with that skill, feeling appreciated for your contribution, and having a sense of gratitude for what life delivers you. And that sounds pretty far afield from healthcare delivery, because it is, and that's a big part of the problem. So a couple of quick quotes. My favorite one from H.L. Mencken, who's the most quotable writer ever, is, "For every large complex problem, there's always at least one simple solution, and it's usually wrong." And so if you look at what's going on in Washington today about solving healthcare, they're not only frequently running into the wrong answers, but they're asking a lot of the wrong questions. The sci-fi writer William Gibson famously wrote, "The future's already here, it's just not evenly distributed." And I like to add converged, operationalized, and scaled. And that's particularly true with a lot of the exponential technologies that we're experiencing. Lee Hood, who invented the personalized medicine movement, more or less, said we all need, this is just last fall, we all need massive personal data clouds. As we begin to get larger and larger data sets, and as we get publicly available decision support, we need to be much more engaged in our own health. Frederick Douglass famously said, "It's easier to build strong children than to repair broken men." And I'm on the board of a foundation right now which focuses substantial resources on exactly that, dedicated to early parenting and early childhood experiences, and I'm going to come back to that. And then finally, Larry Smarr, a friend and hero, has said that your immune system is booted up by your microbiome. So the gut, the bacteria in our gut really do have a profound influence over our health, which is under-recognized in healthcare. So I'm going to shift gears a little bit and talk about what I see as the 6 critical gaps that we need to pay attention to in terms of how we manage personalized health in a community context. And these have all emerged in just the last few moments of human history to a great extent. So the first I call the evolutionary behavioral gap. So our genome has evolved over millions of years, but did not evolve around optimizing life for a couch potato. The blue zones really articulate how a long health span and lifespan is related to a very, very active life, which many of us have lost. Once again, the neglect of the focus on, everybody knows about sleeping, eating, and exercise, but the focus on the health of our social communities is something that's universal. Esther Dyson has been doing some really innovative stuff in her project called Pathways to Wellville, where she's looking at communities, and some of them the most distressed communities on the planet, and trying to apply these principles towards community health to look at the net benefit in health outcomes. The second thing is that there's a gap between the evolution of all the exponential technologies that we're increasingly familiar with and the translation of those to the bedside. So Richard Barker of the UK has written a brilliant book on this very issue. And we really need to look more seriously about how we converge and translate that work into public health outcomes. The third is the empathy gap. And as everyone knows, about half of all primary care docs in the US, the UK, and many other countries are really burned out. I mean, they're clinically burned out. A study reported recently showed that medical students, before admission to medical school, generally have healthier profiles than their peers applying to other programs, but by the time they finish residency, they're at the bottom of the heap. So there is the influence of time pressure on physicians is really a problem. The fourth is the incentive model gap, and that's about healthcare reform and whether it's value-based or fee-for-service, and that's the discussion tomorrow morning that's going to be on a panel with John Halamka and others. The fifth gap is restoring agency to the individual. So I like to describe patient-centric as an oxymoron. It's quite au courant to refer to patient-centric care. But if you think of it, patients are what doctors call people. And it really reduces the individual to someone with an array of diseases or disorders, when in fact it is the broader context of living, including the social milieu and their social support structures. And so we need to find a way to restore a lot more agency to the individual. And there are a number of technologies that are associated with that. And then the sixth one is the lifespan health span gap. So if we can live to be 90, but we're only healthy until we're 70, that's 20 years of ill health. And how do we close that gap? And I think it requires this personalized framework within a community health framework. So I mentioned earlier that the evolutionary gap, this is how many of us have adapted to modern demands on our lifestyle, very dysfunctionally. And the other one, thank you, McDonald's, is Homo fast foodorus. And so these are well-known consequences of a couch potato lifestyle, but what a lot of people don't recognize is how much of our current healthcare crisis is related to these disorders of lifestyle. I mentioned physician burnout. This is a cartoon from 6 years ago in the LA Times showing a physician with 10 arms and still not able to keep up with the demand on their time. And so burnout doesn't leave a lot of room for empathy. So how do we use more advanced technologies? How do we restore more agency to the individual? How do we close some of these other gaps so the physician can actually engage in the human side of medicine? And it really is a challenge. It's almost become cliche, but the truth of the matter is it's really a crisis. So I'm going to walk through a series of random facts, and they're random only in the sense that they don't seem to relate to each other, but I'm going to then tie them back into the thesis of how community health and personalized medicine are necessary to rethink what we're doing. So everybody knows the microbiome is important, but every day there's more profound insight into how it works. We now know that the microbiome has a circadian rhythm and that microRNA leaks across the bowel into the bloodstream and has a direct and profound influence on the regulation of our genome. So all of our genes are up and down regulated massively throughout the day, and it turns out that a lot of that up and down regulation is related to the microbiome. Changes in your microbiome also affect food cravings. The second is around edge analytics and the IoT. So a lot of what we're doing with technology now has to do with the topology of a network and where you do the analytics and where you store the data and how you manage that over time. And there's some fascinating work on human vision recently showing that there is pre-processing, essentially the biologic equivalent of edge computing in the eye before data is sent to the cerebral cortex for processing for vision. And in that context, we're seeing more evidence of how biomimicry is implemented in the topology of networks. The third is an observation that was published recently about cognitive decline. About 2/3 of our population carries a gene which, when activated, leads to rapid cognitive decline in the 60s. Turns out that, as common as that is, the cognitive decline that ensues is only evident after that viral activation. So again, highlighting the interdependence of nature and nurture on the impact in our health. The full impact of lifestyle disorders is we know it's huge, but consider this. The cost of direct care for type 2 diabetes in this country is about 10% of the healthcare spend. That's about $270 billion annually, which exceeds the spend on all energy, which is about $200 billion annually. And that 270 for type 2 diabetes doesn't include all the other comorbidities and disorders of lifestyle. So obesity and inactivity not only leads to type 2 diabetes, but various forms of cancer, cardiovascular disease, stroke, and many forms of dementia. So when you add all these things up, and we're talking about healthcare reform in the terms that we're talking about now, we're really missing a lot of the bigger opportunities. The fifth one is the social support structure. So Carnegie Mellon did this fascinating study a couple of years ago. They took 400 subjects. They exposed all of them to the same dose of virus and looked at who got sick and who didn't and how sick they got. And then they looked at their timeline from Facebook and some questionnaires on the resilience of their social support structure. And what was most fascinating to me is that people who were under a lot of stress got more, they were more affected and more of them got sick unless they had a strong social support structure, in which case they did better than people who weren't as stressed but didn't have that social support structure. So the significant influence of our community is something that we need to pay a lot more attention to. This is an homage to Larry Samar, who's been one of the pioneers in microbiomics, and as you can see, we have more bacteria than cells in our body, 100 times as many genes in our gut as in the genome. You can tell if a child has had a C-section 5 years later by the pattern of bacteria in the gut. There's over 100 diseases with microbiomic signatures. Every organ, including the brain, has a microbiome. Pathologists only recently discovered that there's a lymphatic system in the brain. It was known forever that it was the only organ without a lymphatic system. Well, not true. It has its own. And there's this huge linkage between the microbiome, the genome, the immunome, and the neurobiome, as illustrated by activation of that gene by a viral infection that leads to accelerated cognitive decline. And I mentioned the circadian rhythm driving gene expression. So, second set of random facts. Adverse childhood experiences. How many here have heard of the ACE studies done like decades ago? Okay, so that was done in my institution in San Diego decades ago with the CDC, looking at how adverse childhood experiences influenced health over a lifetime. And it's profound. The statistics has been validated. The statistics are overwhelming. There's a professor at University of Chicago who's looked at intervention to prevent adverse childhood experiences and prolonged stress, and shown that there's a 7-fold return on investment. It doesn't happen in a stock market reporting quarter. It happens over many years. So getting people to invest in a space where the return is downstream is very difficult, but the impact is profound. So we really need to start thinking about a pan-generational and a trans-generational approach to building stronger personal social support systems. The 7th one is that motivational science is really coming of age. How many have read the Daniel Pink's book, Drive? Anybody? Handful? Okay. Highly recommend the book. It reviews the experimental psychology of decades ago with some really profound implications for what we do right and what we do wrong, mostly the latter, in motivating people in healthcare. We need to learn, and I'm going to talk a little bit more about this in a minute, how to create, rather than drug formularies, motivational formularies with what I call motivicons, because everybody has a different personality when it comes to what motivates them. Some people really respond to humor and others are just completely turned off. Some people really respond to very directive, thou shalt do this and this if you want to live. And other people really want to have shared decision making with their professional caregivers, and others want to vet it on their social network or with their immediate friends and family. So knowing who's who and how to deliver the same message to different people with different motivational profiles is something that we need to begin thinking about as a motivational formulary with motivicons. Motivicons being either video or in-app rewards or text messaging or various ways of doing it, but different people really respond. So there's a bunch of great apps out there today to motivate people, but most of them, for the most part, are one-trick ponies, and they just take one method and go after it and wonder why they're only getting uptake in 10 or 15% of the population. There is an exception, and I have no financial interest in this, but Frame Health is one I've been working with for about 5 years. We're seeing some very interesting results by tailoring the motivational context of personalized care. So the 8th one is empathy through virtual reality and physical transfer. Has anybody heard of what physical transfer is in virtual reality? Okay, in the Stanford Virtual Reality Lab, they've done something really interesting. They take an individual and have them identify with the entity that they are in a social context, and then they physically transfer that image off into the distance. So you're suddenly watching yourself, instead of being yourself in a social context, you're watching yourself in a social context, and then they can transform your height, your weight, the color of your skin, your age, your gender, your ethnicity. And what they're finding is that once you've identified with that individual, it's much easier to become empathic with your identity as it changes. And I have this fantasy that I hope will come true someday is when you look at the standardized tests for detecting implicit bias, and we all have implicit bias, and there's some brilliant tests that elucidate what our individual personal biases are. My fantasy is that we'll begin applying that implicit bias test at a very young age, finding out where those biases exist, and using something like virtual reality with physical transfer to build empathy towards everyone in our communities. I think that's going to have a profound influence on how we get along as a society, and particularly in an era where polarization is so extreme. 7 is, what did I do? Okay, 9 is the Amazon Echo and Google Home. How many people have an Echo or a Home? At home, okay. This is really interesting because for the first time ever we have technology that generates an emotional relationship. So we've anthropomorphized our car, we've anthropomorphized lots of things in our life, but we haven't developed emotional relationships. And so what's happening there is really profound and leading to therapies as in speech therapy and forming the basis for various medical chatbots. So I'm going to go over 2 common use cases real quickly and then try and tie together all these random facts. So Lucy is a 2-year-old neighbor across the street. Her parents came to me a year ago and said that she had a high fever and a rash. She went to the emergency room for 2 hours. People coughed all over her. They gave up, weren't seen, came home. Next day she was listless. They went back. Exact same thing happened. So bringing about a convergence of technology to address her, all of the technologies I'm going to describe right now exist today. What will happen, so this is Lucy in 2016. In 4 years from now, Lucy will have her own pharmacogenomics and genomics. There will be a way to swab and determine what virus she has, and this already exists, but it hasn't been democratized and commoditized, and know what virus it is and what antibiotic it's susceptible to. That can be emailed to the doc can say yes. It can go to the pharmacy can dispense it, delivered by a drone, full cycle 5 minutes, having the proper medications delivered to the door. So this is Lucy in 2020, rather than in the emergency room twice in a row and not getting treated, but happily recovered. The second use case is around this notion of how we have a conversation and use visualizations to support health between professional caregivers and and individuals who are sick. So 3 conversations: patient with a professional care team, patient with their personal care team, and the patient with the person that houses them. So I like to think of the 45-year-old woman who comes in with new onset of diabetes and hypertension, and what she says is, you know, I'm stressed out and I've got all this stuff going on, and the doc says, well, here's your 3 options. Option number 1, you can absolutely change your lifestyle, and without any medication at all, we can cure both these. The second option is we're going to give you 2 drugs, come back and see me in 3-4 months. And option 3 is some combination of the 2. And the woman says, well, the reason I'm all stressed out is because my daughter's getting married in 3 months. So give me option 2 with the 2 drugs now. And then after my daughter's married and I get all the in-laws out of town, I want option 1, and I'm absolutely going to do everything possible to change my lifestyle. So this really reflects this dialogue around shared decision-making towards the individual's personalized goals and values at that stage and context in their life. And I'm going to skip this slide in the interest of time and very briefly go over what I call the plecosystem economy. So these are the plecosystem refers to multi-platform ecosystem. And there are service platforms, data platforms, API platforms, experience platforms, funding platforms. Everything in here is on an exponential tear. And how we weave these things together, as in the use case that I gave with Lucy about bringing multiple new technologies together in service of the individual, is going to have profound consequences. But really converging, operationalizing, and scaling these things is the trick. And the 5 principles of the plecosystem is exponential growth, synergy and convergence, data liquidity, person centricity, and acceleration with open source. So Baidu, which is competing with Tesla for the self-driving cars in China, has just open sourced their entire software stack in an attempt to catch up with Tesla in the development of autonomous cars. I like to think of what's happening today in terms of our knowledge growth is that it's the exact inversion of the Big Bang. So 14 billion years ago, the Big Bang, all matter and energy were concentrated in a single point in space and time. And after the Big Bang, all matter and all energy has been expanding at an accelerating rate across the universe. What's happening today with our knowledge and our data is that all of those are converging into a single point in space and time at an accelerating rate, so almost an exact inverse. And what we really need is we need social scientists, we need behavioral scientists, we need motivational scientists, we need data scientists, and we need clinicians who have the subject matter expertise across the waterfront in order to really understand this community context and the personalized context of what's happening to people. So it's what I call a metatopical brain forest, and that's a play on the term tropical rainforest, which is the most diverse ecosystem in the world that, oh, by the way, maximally captures and converts solar energy into carbon-based life. So I think that there's an opportunity to bring these disciplines together, to bring a coordination of resources together in a way that's very foreign to traditional healthcare today. And then finally, I like to think about using natural language processing to do neurolinguistic programming and cognitive behavioral therapy. And I like to think about a sage on the shoulder. And I've been talking about this for a couple of years, and I was at a conference in New York last week, and there's somebody doing exactly this on Facebook today when kids are starting to rage on Facebook, to have real-time NLP looking at what they're saying and teaching them how to de-escalate the situation and hopefully diminish the bullying that's going on. So here's my prescription for health. We can and will close all 6 of these gaps, but only after reframing what health is really about and how we achieve it, and create a community-based behavioral symphony of wellness that brings all elements of the community and all exponential technologies to bear on the health of the entire community. We need to explore pan-generational and trans-generational approaches to restoring health to every member of our communities with a renewed focus on parenting and early childhood experiences to build resilience in all of us. So hopefully we can approach a global blue zone that doesn't look like 5 isolated communities. And then the last thing I want to mention is Hubert Humphrey. This is hanging in a big bronze plaque in Health and Human Services. He said, it has been said that the moral test of government is how that government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. So I think it's incumbent upon all of us to pay attention to what we do in terms of its unintended impact on rising social inactivity. So I'll stop there. Thank you very much.